Tēnā koutou katoa. Welcome to day 28 of lockdown. Today we are blessed to have Chelsea Langram with us, who is going to share her wealth of knowledge on skin cancer, early detection, early intervention and prevention. Chelsea is a registered nurse with 16 years experience as a specialist skin cancer nurse. Her passion is in raising awareness of skin cancer, including the use of technology. Chelsea recently started her business, Skin Aware, that focuses on helping workplaces to implement UV awareness and screening programs. Chelsea also provides education and training for registered nurses. During the webinar, please continue to feel free using the chat function to introduce where you're from. And there's also the question and answer function that can be used to submit any questions you may have along the way. I'm very interested to hear what Chelsea has to say tonight and looking forward to the break from COVID. And I'll now hand you over to Chelsea. Thank you.
Thanks, Catherine. It's great to be here tonight, and thanks to all the people that are giving up an hour of their evening to sit and listen to a different topic than COVID-19. Another very important topic, though, in New Zealand, nearly as big as COVID-19, skin cancer. Just quickly, a little bit about myself. I am Australian. I've lived in New Zealand for the last 16 years. And in that time, I've lived in New Plymouth, working as a skin cancer nurse in primary healthcare. And I've been doing that for 16 years in the surgical side, as well as then training in dermoscopy and becoming a screening nurse as well. 18 months ago, I decided to have a change in my job, and I started a business here in New Plymouth where I mainly work with workplaces in running skin cancer screening programs to kind of fill the gap from the doctors getting busier and not being able to get out as much, and also educating in workplaces as well. And I do have a passion for preventative healthcare and also technology use in healthcare as well. So firstly, I'd just like to acknowledge the use of images from DermNet used for education purposes. Sorry, there's a little bit of a delay sometimes with my slides. Then it goes too far. Okay, so to start with, we have just some facts and figures around skin cancer in New Zealand. Skin cancer is the most common cancer in New Zealand. It's about 80,000 skin cancers diagnosed every year in New Zealand, roughly, and 80% of new cancers in New Zealand are skin cancer. New Zealand's got the highest rate of melanoma in the world, alongside Australia, and over 4,000 people are diagnosed every year with melanoma. It's about 13 people a day. Over 350 people die from melanoma every year, and that is more people than in killed in road accidents. Melanoma is 95 to 100% curable if it's detected early and treated quickly. Just some other interesting facts around sunburn. 1 blistering peeling sunburn doubles your risk of melanoma. 5 peeling sunburns gives you an 80% chance of melanoma. So it's hugely important in our young generation of children under the age of 20 that we really encourage sun-safe practices. They're the age group that get a lot of exposure. Sun exposure is cumulative and it adds up over time, and this is why we see such higher cases in over 50-year-olds, especially a lot of them haven't had a lot of sun protection. But coming through now, it is a cumulative effect, and so often we don't see it until later. Outdoor workers have get up to 10 times more UV exposure than indoor workers, so they have definitely a more risk and people to look out for. There's a huge cost to the country in dealing with skin cancer in New Zealand. Rough approximates, unfortunately the information, some of it's old, but they estimate that we spend about $125 million on just treating skin cancer in New Zealand, and that's not with prevention. Unfortunately, with prevention, the health promotion agencies do an amazing job in this area with very limited funds, and it's very sad that around skin cancer there hasn't been any campaigning in this area for over 10 years. And it is a very preventable disease that we should be doing more about in New Zealand. So the contributing factors to our high levels of skin cancer is, the biggest one is UV radiation. So we have high levels of UV radiation in our daylight savings months from September to April, and also, of course, the ozone layer. We, over the southern hemisphere, the ozone layer is a lot thinner than the northern hemisphere, and we get about 40% more UV than the northern hemisphere and the southern hemisphere. We have very clean air here, so we don't have a lot of protection. The good news with the ozone layer is that they do a lot of studies and keep a very close eye on it, and they introduced the Montreal Protocol back in the 80s to help protect the ozone layer, and this is working very, very well. It's where they banned the CFC products, and it's been one of the best environmental projects ever, and so that's very good. So we know that the ozone layer isn't getting any worse, it is stable, but it's not getting any better either. And so we have to live with it in the southern hemisphere. It's something that is part of our lifestyle, and so we get high levels of UV radiation. There's 3 different types of UV radiation that we receive. 2 of them we get, and 1 we don't get a lot of. So there's UVA, UVB and UVC, and you can see in the picture here, they're all differing lengths. So UVC has a very short wavelength and it gets reflected back into the stratosphere. The only time you can get UVC is if you're an arc welder and you're not protected. So people welding do need to be well protected from UVC. The 2 that we get the most of though is UVA and UVB. UVA is a very long wavelength. It goes very deep into our layers of our skin, so it goes down to the deep in the epidermis, to where the basal cells are. UVA is the cause of our aging and our aging spots and our wrinkly skin, and it's the cause of basal cell carcinomas as well. And we get a lot of UVA all year round in New Zealand. The other UV is UVB, which is a little bit shorter wavelength that goes into the more superficial layers of the epidermis where it affects the squamous cells and melanocytes. And this is the cause of our burning when we burn. So and causes melanoma and squamous cell skin cancers. The thing with UV radiation is can trick people a lot. Firstly, it is carcinogenic to humans, so we know it causes cancer, and that's a real concern. It cannot be seen or felt, so it can be difficult. We often might have a bright day and think we need to be more protected, but actually even on cloudy days, UV can come through 80% cloud. And it can also pass through loosely woven clothing and reflect off surfaces. But what we know is 95% of skin cancers are caused by UV radiation. So it's something that we need to be well protected from. Other contributing factors are the use of artificial radiation, which is sunbeds. Unfortunately, in New Zealand, sunbeds haven't been banned as yet, like many other countries. Again, this is another thing we're working very hard on. So anyone over the age of 18 can use sunbeds still, but we definitely encourage no one to be using them. We also, our outdoor lifestyle and tendency to seek the outdoors in New Zealand. We live in paradise, but it does come at a cost, unfortunately. Yes, we do have to be careful, and poor use of sun-safe practices. We are improving in this area, but again, as I said about the campaigning, there really needs to be more awareness around. So we have our own risk factors as well that are non-modifiable. So if we look at age, over 70% of melanomas are in people over the age of 50, but no one's immune. We do see melanoma and other skin cancers in younger people. It is very rare in children, but it can occur. In gender, unfortunately, the death rates from melanoma are higher in males and increasing. Latitude, where we live in the southern hemisphere is obviously we're at higher risk. Where we live within New Zealand, not a lot of studies being done on why some areas have higher levels of melanoma than others. It could be different groups of working groups that live in areas like farming areas to roading construction. Our skin type is a huge risk factor. Unfortunately, in New Zealand, fair-skinned people the sun absolutely loves. But if we look at the Fitzpatrick scale, which is the guide to skin types, and the 6 skin types we have, is it starts at skin type 1, which goes through white, very fair-skinned people, red or blonde hair, blue-eyed, people that are freckly, that always burn and never tan, down to someone with black skin that never burns but tans very easily. Skin cancer does like fairer-skinned people, unfortunately, and so our large population of fair-skinned people here in New Zealand gives us a higher risk. Atypical moles, some people with lots of moles and lots of freckles do have gives them higher risk factors, and people that have had lots of sunburn, use sunbeads. Anyone with a past history of a skin cancer or a melanoma has an increased risk and differing levels. If there's a family history of a first-degree relative, they have definitely a higher risk, and their own personal history, they're more likely to get a melanoma. If anyone with weakened immune system does have a higher risk, and as I said, outdoor workers. So there are some risk assessment tools that you can use in your practice. BPAC have one available that was developed by Dr. Jane Snyde from down in the South Island. And so if you're using indices and MedTech, I'm pretty sure it's all integrated there. I haven't personally used it. There is another one called Scan Your Skin, which is by the Skin Cancer College of Australasia as well, and that's a very good one. But this is the best practice one. It's just a screenshot of it, and you should be able to access that on your systems. It gives you, it's a guide to help you with when you're working with people with skin cancer or what their risk is with their risk factors. So I'm just going to show a short video, and this just explains I just like it because it explains quite clearly the cells and how they're damaged from being sunburnt, and then we're going to talk about skin cancer, so it kind of makes sense then to show what's happened.
I sunburn super easily. It just takes a few minutes sitting in my garden or on a beach, and then a couple days later, my skin starts peeling off. It's seriously pretty gross. Not exactly the effect most people go for when they sunbathe. But what really happens when you get a sunburn? I'm Anna Rothschild, and this is Gross Science. Most burns occur if you come in contact with something hot, like when you scald the roof of your mouth on a slice of pizza. But sunburns are actually not caused by heat. Sunlight is made up of a bunch of different types of radiation. One of them is infrared radiation, which is primarily what makes sunlight feel hot. But there's also visible light, which allows us to see sunlight, and then there's ultraviolet radiation. Ultraviolet, or UV radiation, is what causes a sunburn. It can wreak havoc on skin cells by disrupting important molecules like DNA. So your body does its best to protect you from it. When UV radiation hits your skin, pigments called melanin absorb it and shield your DNA from harm. Now, melanin is present in our skin cells all the time. It's what gives your skin its particular color. It's created by special cells called melanocytes, which then distribute the melanin to other cells called keratinocytes. Those are the most common cells in your outermost layer of skin. When your skin is exposed to UV, the melanocytes ramp up their melanin production and also transfer more melanin to the keratinocytes. This happens to varying degrees based on your genetic makeup, but that's why your skin might turn darker or tan if you're out in the sun for a while. But the melanin defense is far from foolproof. Regardless of how dark your skin is or how much you tan, some UV rays can sneak past. And when they do, they can damage your DNA. This can actually happen in a few different ways. Sometimes the radiation will directly zap your DNA, damaging it in just a trillionth of a second. Alternatively, UV rays can do something more sinister. They can actually turn your melanin against you. The radiation can make your cells produce these harmful molecules called free radicals. Now, this is a little bit complicated, but essentially, the free radicals excite an electron in your melanin. I'm excited. The melanin then bumps into your DNA and excites an electron there. I'm excited too. Which can cause the DNA to kink. Regardless of how it happens, once your cells are damaged, they start producing warning molecules, signaling that something bad is going on. If enough cells produce the signal, your body will mount an inflammatory response, sending lots of different types of blood cells to the area to stop and repair the damage. And it's this influx of blood that causes the redness you typically see with a sunburn, depending on how light your skin is. So what about the peeling? Well, your skin cells are shedding all the time without you even noticing it. You actually have stem cells in your skin that live for decades, and the stem cells produce layers of keratinocytes which fall off and are replaced over time. But those keratinocytes don't mature properly when they're damaged by UV. So instead of flaking off inconspicuously, they all clump up and peel off together. Now, your body actually has enzymes that repair a lot of the DNA damage caused by UV rays, but it can't always repair all of it. If the damage isn't fixed in one of your stem cells, you might have a real problem. When those cells replicate, they might create a mutation at the site of the damage. And depending on where the mutation occurs, this could lead the cells to become cancerous sometime down the road. Remember, even if you don't tend to burn, UV radiation can damage your DNA. So if you know you're going to be out in the sun for a while, make sure you're covered up or wearing sunscreen. For me, being outside and exploring the world is super important for my happiness and excites my curiosity. But it's way more fun to go on an outdoor adventure without coming home to disgusting, peeling skin. Ew.
Okay, sorry, I cut that. That was finished anyway. But yeah, I quite like that video. It explained it really well to me. And so we're just going to move on to types of skin lesions. There are many, many types of different skin lesions, and I only have such at 1 hour to talk. So I've just picked some that we see a lot of, the common types, to go through with you and show a few photos and talk about. So we're just going to start with benign lesions and talk about common nevi. So a nevus is a common benign skin lesion, which has got normal tissue that presents in abnormal amounts or patterns. There's many, many different types of nevi that you can get, and some of them can resemble melanomas, so it can be a little bit difficult, but most of them are harmless. Moles can appear at birth, or they can appear later on as we are aging. Commonly though, moles over the age of 40, we do stop producing. So over the age of 40, it's very, very important to learn if someone's getting a new lesion, how it's evolving and what it's doing, because it isn't as common to acquire moles over that age. Who gets moles? We all tend to, almost all of us will have at least one mole or more. They are more common in fair-skinned people. You often get, who gets moles? Most of us have moles. Fair-skinned people tend to have more moles. We tend to acquire them in early childhood or sometimes in adolescent to in our 20s. And most fair-skinned New Zealanders have 20 to 50 moles. There's atypical moles that we get, which is one I'll talk about because you may see it in practice, and it is they are unusual moles and they can resemble melanoma. So it's good to talk about these because they can be hard to assess and look at. An atypical mole has very unusual features. If it's tested histologically, it may show that it's a dysplastic mole. They can appear sporadically or familial. The features of them are often that they are large, can be unusual shapes, irregular borders, and they can be varying shades of colour. And often people may have many of them, and so these types of people with lots of moles can be very hard to look after, and that is where things like mole mapping come into place to help assist the clinicians with looking after these people, because sometimes trying to find the melanoma in amongst all these moles can be really difficult. And you'll see here on the next slide a patient with, we call it atypical mole syndrome. It is a type of syndrome where people that have many moles, it's probably passed through genetics, but you can see someone like this, if you were looking and doing a skin assessment on, they can be very, very tricky to assess and look at. Using total body photography now and artificial intelligence is just a game changer for people like this. And it can be sometimes like trying to find a Pikachu in amongst this puzzle. It can be very, very hard to find the melanoma amongst it. I'll let you have a quick look and see if anyone can find it, but it's pretty hard on the ear. Okay, moving on to more common benign lesions, seborrheic keratoses. You'll see a lot of seborrheic keratoses. These are aging spots, often come as we're aging over the age of 30. They're usually rough, scaly, like wart-like, and they're harmless. They can be varying colours from skin colour to dark to black, and they can be large, they can be symptomatic, they can be itchy, and sometimes they can be irritated, so they may bleed, and so they can sometimes resemble a squamous cell carcinoma or something more serious. So you do have to be a little bit careful with assessing them, because they can sometimes present slightly differently. As you can see on the man's back, he's got many, and so again, when you're assessing someone's skin like that, it can be hard to find them, looking for melanomas in amongst that as well, not getting distracted by all the seborrheic keratoses. But these can be, treatment-wise for something like this, they can be sprayed with liquid nitrogen, sometimes shaved biopsies, or just left alone because they are harmless. Solar lentigo are a sunspot. They're very, very common, and they can be from acute or chronic UV exposure over many years. And you often see them in sun exposed areas to the sun. They can be of light pigmentation and get darker. You can get slow growing melanomas in amongst lentigo, so you do have to monitor these as well. They are commonly on hands and face, dorsums of hands and faces, as the pictures show. And the main management for these lesions is sun protection, really, and it's amazing what sometimes sun protection can actually reduce the amounts and the way they present as well. So otherwise there are topical ointments or light freezing sometimes as well can work well for solar lentigo. Dermatofibromas, another common lesion. You may or may not have heard of them. There's many types of fibromas, but this is the most common type. They're usually from an inflammatory response like a mosquito bite. They often look unusual, so people are usually alarmed by them because they are something, though I see a lot of them, you might not have seen many. They usually got a little bit of a hard centre. They may be shiny or a bit smooth, or they might be a little rough even. They usually have some pigment to them though. You can do a pinch test on them and they usually dimple in the middle, and that gives you an idea that it could be a dermatofibroma. But unless you've seen a lot of them, you would never be able to make that decision. But they are harmless, and they're usually from a mosquito bite or some type of inflammatory response. Vascular lesions, again, there's a few different types. These are just a couple: hemangiomas, cherry angiomas. Cherry angiomas, which is the lesion on the right, they're very, very common. We see a lot of these on people, again, with age. And and you can get varying numbers of them. Some people get lots. You can also see them in pregnancy. Some pregnant women may get a lot of these lesions as well. They're often little bright red papules and just bunches of blood vessels that have accumulated together. And often you see them mainly on the trunk. So we're going to move on to malignant lesions now and talk about melanoma. So as the video showed, we have melanocytes on our skin. If we have too much ultraviolet radiation and the cells, the DNA is affected, the cells may start mutating to cause melanoma. Melanoma is the most life-threatening form of skin cancer. The reasons being in its later stages, it is deadly, it spreads throughout, can spread throughout the blood and lymphatic system. If it is treated early, in its early stages, it is easy to treat, and there are good treatment options for melanoma. The clinical features for melanoma are often, there's many different features again. No problems with sound? No, it's all good. Yeah. So melanoma can occur anywhere on the body, and you can get melanoma in unexposed areas as well. So you can get melanoma on the eye, you can get melanoma under the fingernails, soles of feet, palms of hands, anywhere where there is skin. 95% of melanomas are from UV radiation, and there is a small percentage of melanomas that may come from genetics and our risk profile makeup. So the most common type of melanoma we see is superficial spreading melanoma, and it is a flat melanoma on the skin. It might be a large lesion, a funny shape, unusual colours. Melanomas are often more than one colour. They often are large lesions, and they can be multiple. colours as well, from going from brown to black, purple, blue, white. You can get, as I said, melanoma under the fingernail in the picture over here. And what you're looking for with something like that is if you jam your finger in a door, melanoma will, the bruising will grow out. With the melanoma it doesn't. So you keep seeing something under the nail that never goes away. Often these types of lesions may be left not being checked so early, so they can be quite aggressive melanomas when they get treated. An ugly duckling, a lesion that just may appear, and it might be standing out, so it doesn't have another friend or another lesion that looks like it. So someone with many moles, you might see they all look similar, but if you see like the lesion on this man's back, there's only one and it's large and it stands out. It's really important to look at that closer, and sometimes it may be absolutely fine, but it is definitely worth looking at. The other last feature of melanoma is a new lesion. So looking for anything over the age of 40, our mole production slows down. So if you notice any new lesions coming up and they've come up quickly and they're raised and they don't go away within 4 to 6 weeks, it's very important to encourage the patient to get it checked. Invasive nodular melanoma can change to be aggressive within 6 to 8 weeks. And so anything new that doesn't go away, that doesn't look like anything else, you can't, it needs to be reviewed quickly. So sorry, just down the bottom, you can see the last lesion is slightly pink. So sometimes melanomas can be pink as well, but something raised, fast growing is very important to get checked. Melanoma doesn't discriminate. Anyone can get melanoma. So at any age group and any skin colour. So we do see low numbers of melanomas in Pacific and Māori people, but often they can be more aggressive. So yes, we do see low numbers of melanomas in dark skinned people. So just something to be aware of. Okay, squamous cell carcinoma. We have squamous cells that make up our skin cells. And again, if they're mixed, affected by ultraviolet radiation, and the cells may mutate to cause squamous cell carcinoma. This is the second most common skin cancer. It can be slow or fast growing, sometimes more slow growing. It is rarely fatal, but if it's left untreated, it does have a risk of spread. So it's very important that it's treated properly. The signs and symptoms of squamous cell carcinomas are often rough, crusty, non-healing lesions. They're very, very common on sun-exposed areas like the head and neck, the forearms and tops of hands and lower legs. We do see squamous cell carcinoma. Smokers have a higher risk of getting squamous cell on the lip. And you can see in these pictures, the man's hand, there's lots of rough, crusty areas, but there is a spot right in the middle of his hand that was a squamous cell carcinoma. And the lip, obviously, that is a nasty lesion on his lip. But yeah, so smokers do have an increased risk of squamous cell carcinoma. Management of squamous cell carcinoma is excisions, topical ointments, some light freezing with very early squamous cell in situ possibly, and then we have basal cell carcinomas. Basal cell carcinoma are the most common skin cancers that we see in New Zealand, large numbers of, and they are the least deadly though. So if they were left untreated, they can be very destructive in the area they form, and they often form in tricky locations. So they often come up in areas that have seen a lot of sun, like on the head and neck areas, but they may be on the very edge of your nose or the very tip of your ear, and so they can be quite tricky to treat. But they can present as pale, red, pearly, smooth lumps. They might not be healing. It might be like a little pimple that just never goes away. Something that bleeds but just never heals up. You can see in these pictures here that there's a tiny little pimple on the edge of the nose there that would be hard to pick up, but it was a basal cell carcinoma. Rough, scaly spots. Then we move on to precancerous sun damage, or other known as actinic keratoses. Actinic keratosis is very, very common in New Zealand because of the chronic sun exposure we get. You especially see it in farmers and builders that work a lot outdoors. And they're often rough, scaly patches similar to squamous cell, and it is they can slowly change into squamous actinic keratosis over a long time. So there are sunscreen is the best for these for actinic keratoses, or other treatment options. Often people have light freezing, or they may use some topical ointments like Fitzpatrick or PD photodynamic therapy is good also for actinic keratosis, but definitely sun protection is one of the most important things. So you can see here. Okay, so moving on to assessing a lesion. So most importantly, it's really important to get a patient history and as much detail as possible. So being able to do a risk assessment using a risk assessment tool like the BPAC one or the Scan Your Skin is good to get what their risk factors are there, and to know if they've got any history of melanoma or skin cancers at all is good. And then moving on to looking at the lesion and the visual lesion assessment. So the way we commonly assess visual lesions has been the ABCD, and you may have heard of that. It's been around for a long time. We'll go through it in a second. It's evolved and it's slowly added in EFG as well. And so with the visual lesion assessment, you want to get as much information to rule out if it's a melanoma or not and where you're going to move to from there. So it's ABCD is the pigmented lesion assessment. The other things you want to find out is how long has the lesion been present for is extremely important. If it's a new lesion that's been present for just a week, and it's probably best to monitor and see if it goes away. If it's been there for 20 years, it's probably okay as well. But if it's been there for 4 weeks and hasn't healed, then it's of interest, definitely. Is it symptomatic, sore, bleeding, itchy? Do you have any other similar lesions? So can you compare it to something else on the lesion? So let's have a look at the ABCD of a pigmented skin lesion and how to rule out. We'll move there in a second. So the ABCD stands for asymmetry, border regularity, colour and diameter. It's, so we look at a lesion and we'll move on to the next picture, which shows a nice table. So if you look on the left side, you've got normal lesions. So if we look at the asymmetry, we have a very normal benign mole, and then we have a melanoma or a malignant lesion on the other side. And if you think about if you can fold it in half evenly, so I think if I can fold the lesion in half evenly and it's the same on both sides, then that's pretty good. But if you fold the malignant lesion in half, it's not the same on either side. So that's a red flag. B is for border, and if the edges edges on an early melanoma tend to be uneven. They're not very smooth. They can be notched and crusty. So you can see on the benign lesion, it's very smooth and normal, whereas on the other, the malignant lesion, they are very uneven borders. The colour we talked about, a healthy lesion will have a uniform colour, whereas a melanoma may have varying colours, and that's changing from brown then to blacks and whites, pinks and other lesions. Diameter melanomas are commonly larger lesions. Though saying that, we do diagnose them very small now. I had a 2 millimetre melanoma not long ago. Well, it was less than 2 millimetres actually, but it was tiny. So, but generally speaking, melanomas are a growing active lesion and they'll be over 5 millimetres. E is for evolving, and so evolving is where a lesion's changing. So it might have seen it at 3 months and it was, and then seen it again in 6 to 12 months and it's slowly increased in size or slightly changed. So it's evolving. And then they have added in also F and G. F is kind of covering something funny or firm, which was the ugly duckling or a firm raised lesion. And growing is something also growing. So it's slowly changed as we've learned so much more about melanoma. Also looking for anything symptomatic, itchy, bleeding, not healing, or new lesions. This type of assessment is okay for clinicians, but if you're trying to teach a patient to know what to look out for and you tell them, oh, look for colour variation, they're going to be wondering what the heck you're talking about. So the Skin Cancer College have a really good tool assessment as well, and it's called Scan Your Skin. And they have their own website with it, and it has their risk assessment tool as well as the information. And this is very straightforward, and it includes pigmented lesions as well as the non-pigmented skin cancers. And so SCAN stands for sore, so a spot which is sore, scaly, bleeding, itchy, symptomatic. C is for changing in size, shape, colour or texture. A is for abnormal or the ugly duckling, something that stands out. And N is for new, where we talked about a new lesion, especially over the age of 40. So that is a very good acronym. I think that even for clinicians that are not highly experienced in this area, it is a nice, easy acronym to follow. And as I said, they do little brochures and lots of resources as well that is useful. And then we move into what I love is dermoscopy or photography, which obviously is an area that, like any additional service or tool, is something that you do need to have extra training in and have to have worked in it for some time to be good at. But really importantly, just with a skin lesion, is taking a photo. And for people that work in isolated areas or on their own, sometimes a photo can really help with the management of someone. It might be that you take the photo back to your GP to talk to them about what to do about the lesion, or it might be in a clinic where a GP doesn't have the experience in dermoscopy or skin cancer even, that it means that they can send a photo off with the referral or to get another opinion. So taking a photo just with your smartphone is really handy to do. One of the things you can implement into your clinics is adding on from your smartphone is a dermoscope and taking a little dermoscope, a photo, and then using teledermatology to get the assessment back. And it's very, very streamlined and simple, and you don't need to know dermoscopy as such. And then you get a report, you send it off to a teledermatology platform, which have specialist doctors in the background assessing them lesions, and then you get a report back. So some of the benefits of this are for people, especially rural, that could be travelling 4 hours to go and see a skin specialist, and maybe they don't need to if the lesion is something else. So it could just be a little bit more helpful with management-wise. It's certainly, dermoscopy definitely helps. The clinical information it provides helps a lot for the clinicians working. But I use a small little dermoscope like this, and it's very tiny and it just fits onto my iPhone, and I have a little magnet that attaches to it. You can see. And I'm able to then get the clinical photo as well as the dermoscopy photo, and I can send off them photos. Obviously I store them in my own database, but I can send them off to a skin cancer doctor that specialises in dermoscopy, and it's really great. Dermoscopy wise, this is what you get. So this patient of mine that he has dysplastic nevus syndrome, and he's had 5 melanomas, 4 last year in 1 visit. And so I've taken the clinical photo, they're a bit blurry, sorry, of his leg, and then this is the dermoscopy photo. And so these can be uploaded and sent off, but it does give a lot more information when you get the dermoscopy to the lesion. And that's another classification system that you do have to have done lots of training in to know what to do with that lesion. Okay, so just briefly going through treatment options. So I'll just bring back to melanoma, because I didn't go down the treatment, the management of melanomas, which is really, really important. I'm sorry I missed that earlier. So management of melanomas, obviously the best management is a wide excision, and preferably not a punch biopsy, but sometimes a punch biopsy on a large lesion is the only option. So, and then depending on the results of the excision, and when it comes back as a melanoma, they use the classification systems of the Breslow thickness and the Clark's level to give the clinicians a guide of how they need to treat the lesion. And they follow the New Zealand melanoma guidelines on management of how melanoma is excised, and so usually it's a 10mm margin for Clark's level 1 and 2, and then moving to 3 and 4. They may go into lymph node dissection and different treatment options. So otherwise, the common treatment options that we see with skin cancer is cryotherapy. We use a lot on actinic keratoses, seborrheic keratoses and different warts. It should be used with caution on non-melanoma skin cancers, depending on where they are. Cryotherapy is used on some superficial basal cells and squamous cell in situ. It does need to be used for quite a decent freeze, and so just depending on the location, you do have to be very careful, like on the lower leg or on the face, where on the face they can scar quite badly with cryotherapy. Topical ointments and photodynamic therapy are commonly used for actinic keratosis and superficial basal cells and squamous cells. That's things like Effudex and Aldara. They're very commonly used, and they work very well. Most important that they're used in our autumn and winter months. They're not nice to use when the sun's out. Can make you very, very sore skin. Making sure you've got a good management system in place when people are using Effudex, that they are getting in touch with you and they know, especially in the first 10 days, if they've got any concerns, that you need to be keeping in touch with people. And then moving on to biopsy. So trying to get a diagnosis, of course, with a biopsy for suspicious lesions. So a small punch biopsy is great. They're very easy to do and give us lots of information. Or an excision biopsy, which sometimes is done on pigmented lesions to only take small margins but remove the whole lesion. And then we move to excisions, which includes white excisions, skin grafts, and we'll talk a little bit about Mohs surgery, which is microstaging surgery. This is a surgery that's used for skin lesions on the head and neck, and it's about preservation of as much good skin as possible. It's kind of a gold standard treatment of head and neck surgery, and it's very good for tricky locations on the ala or the edge of the nose or an ear. And then going into immunotherapy, chemotherapy and radiotherapy, it's not my area of expertise, but this is where it's used for more serious skin cancers, melanoma in its later stages, or some squamous cell carcinomas. Just talking about immunotherapy, it's a very exciting area to work in because they're having some really, really great responses from it, and we're really seeing melanoma being people are having stage 4 melanoma, having recovery, which is amazing. So just talk quickly on prevention, as most of you will know all about prevention, no doubt, but prevention is a lifelong effort, and it is our standard slip, slop, slap campaign that has been around forever. So that is the continued thing, adding in self-skin examination as the added extra. I just want to talk about sunscreen because it's a really important topic in New Zealand, and certainly over the last couple of years in regards to clinician-wise. So you'll know that sunscreen needs to be broad spectrum, so it needs to cover for the UVA and UVB, which I talked about earlier as both the UVs that we get. So we need to be a bit careful there because unfortunately New Zealand's sunscreens aren't regulated. And so anyone can produce a sunscreen, and other places around the world as well aren't as regulated. There's lots of sunscreens available that only cover for UVB, and so they're not covering for the UVA. So they'll be missing out. They might be the SPF 30, but they're not covering for UVA. And we get the most UVA out of both of them. So it's important that the SPF is at least 30. It's just in Australia now, the recommendations are only for over 30. They don't recommend under that at all. You could get away with the 15 plus in winter months, but over 30 to 50 is the highest. And so it gives you 96.7% at a 30 plus or 98% at a 50. No sunscreens completely blocks full UV. The higher you go, the more chemicals are added. So the recommendation is 30 to 50 is absolutely fine. So just wanted to really make you aware that in New Zealand currently, sunscreen is classified as a cosmetic, and the working groups around prevention, skin cancer prevention, are really pushing for the government to change this to a therapeutic, and it is in the new cancer care guidelines that come out, so hopefully things will change. So Australia, their sunscreens are under the Therapeutics Goods Act, and they have to be assessed, and then they've got a number on the front. So I kind of encourage people to use Australian-made products. But again, I don't know that their system is actually fully, there's still a lot of work to go on in regards to sunscreen, and that's being brought up, and all around the world there needs to be some work, because it's a very important product that we're putting all over ourselves, and we need to know that it is safe. You can find more information in Consumer New Zealand, but just make sure that if you're talking to people, they make an informed decision and that they're aware of it. So I talked about self-examination. This is being pushed a lot to really encourage people not to rely on a skin check or their mole map every year, but in between times learning to check their own skin. They need to check their own skin all over their body. So front, back, behind ears, soles of feet, palms of hands, areas that don't see the sun as well. So again, Scan Your Skin has good information for patients about scanning your skin for melanoma all over your body. But yeah, self-examination is very important to encourage for people. A couple of times a year, do it themselves, and then have their skin check as they feel they need it. Getting to know the UV index is another really important thing. So we're really conscious of what the temperatures are and watch the news and the weather and how hot it's going to be. But learning how to understand the UV index is really, really important as well. And it's important to encourage your patients to learn about it. You can get apps to go on your phone. SunSmart have a good little tool that you can put on your computer to tell you each day, but you can get little third-degree apps to put on your phone that give you good information around this as well. Vitamin D, it would be something I'm sure some of you are thinking about, and around this area. I've only done a tiny little bit on it, added it in quickly. So sun exposure is the primary source of vitamin D for most people. So we're really efficient at absorbing vitamin D just on a daily basis if we're healthy, normal people going about our day and heading out to work and in and out of our car dropping kids at school. We are getting a decent amount of vitamin D. If we are compromised and have maybe had skin cancers or immunocompromised, then we may be more covered up and not going outside. So these people may be at more risk of vitamin D deficiency at some stage, or may need supplementation. Sun smart behaviour doesn't mean avoiding the sun altogether. So it's going out in summer before 10 o'clock for maybe your walk from 8 till 9 or 9 till 10, or later in the day. It's just being smart when you choose to do it. In the winter months, you may need to make yourself go out a bit more to get that vitamin D that you need in the colder days and that, but it is good to try and get out there for at least half an hour and get some sunlight. Yeah. And important to get them 16-year-old boys outside of their rooms with their curtains up. There's a few problems there. Yeah, so just take home information now from tonight. Some really important resources for you is DermNet is an amazing website, and you can get so much great information off there. SunSmart New Zealand is good. There is a nursing little course on there. You can get some professional development hours from if you need it. It's on SunSmart. Melanoma New Zealand and Melnet are just some non-profit organisations working in the area. New Zealand do great stuff. Scan Your Skin is the Skin Cancer College, BPAC. And then if anyone's interested in dermoscopy, Dr. Amanda Oakley does a Chaos and Clues in Dermoscopy Study Day, which is well worthwhile. It's a very good start. The Skin Cancer Symposium also do some basic dermoscopy courses now as well. And then Health Certs is an Australian one that does bits and pieces. First Check and Derm Engine are teledermatology sites that you can access. And that is the end of my talk.
It's wonderful, thank you. You poor thing with your computer, eh? And you couldn't call it one bad name the whole way.
I say that I enjoy tech stuff. I can't get my computer working.
All right, so you've got time for a few questions, Chelsea. Is that all right? So in terms of your questions, here we go. Hi there. Do you ever use the Clues and Chaos system or prefer this one?
Yeah. I use Clues and Chaos system is for dermoscopy, so I use that all the time. The ABCD is the visual assessment of pigmented skin lesion. So it's the first process.
And then we've got, now you kind of answered this, but I said we'd ask a question. So any brands of sunscreen you would recommend?
Yeah, it is a hard question. As I mentioned, I said Australian made kind of brands, but La Roche-Posay is a French brand that's manufactured in Australia, which is very, very good. I personally used it and lots of people have used it. It's tested dermatologically as well as in pediatrics as well. And it's a good sunscreen. I think it won best sunscreen in the world not long ago as well.
Right, and then we've got, with time, do you become more skilled at dermoscopy, recognizing suspicious lesions? Also, any online service in South Island for teledermatoscopy? Most DHBs have some weight. Also, the surgical skills to remove some appropriately. Thank you. A lot of questions there.
Yeah, so let's go to the first part of that question. You have to look at a lot of skin to get good. So it takes about 500 skin checks to see a melanoma. So you get better in time, definitely. But it is a lot of skin checks to get good. Yeah, we've got to be doing it, you know, a reasonable amount. In regards to the South Island, you can use teledermatology from anywhere. So things like First Check is a New Zealand teledermatology. It was made for consumers to use actually, and they have a little skin scope that you can buy and attach to your smartphone. But I use it personally in my business because though I know dermoscopy, I also only know a small amount of dermoscopy. And so I seen lesions through First Check as a clinician. And they are helping GPs to implement teledermatology with their platform. And so, yes, you can contact First Check and they can help you to set that up. And it's very straightforward.
What are your thoughts on Daylong?
No, I would never use Daylong. There's no sunscreen that can last 8 hours with New Zealand sun and the high levels of UV we have. I believe Daylong got taken off the market for some time. Maybe there's others that are back on, I'm not sure.
And we've got, how do you recommend nurses go about completing, I struggle with this word, dermoscopy course, yeah, it's one of those, that's my word, courses.
Yeah. Look, it's definitely a framework I'm really interested in working more with to develop some maybe better track for nurses to go down. But as I mentioned, the Chaos and Clues course that Amanda Oakley does, if you're working and seeing skin cancers, then it is a great course to go to. And then the Skin Cancer Symposium does like a basic dermoscopy course as well. So, yeah. And DermNet has lots of basic dermoscopy information.
Sorry, still on silent there. How important are expiry dates on sunscreens? We all have a bottle in the cupboard which is out of date. Can we still use it?
They say no, you can't. They say that they do lose their lifespan by about 18 months. You do have to be careful with sunscreen in cars over, if they're sitting in hot cars, they may also lose their efficiency to work.
There's a couple of questions around the First Check, but where you find the contact details and the cost involved.
Yep, sure. So First Check, you can either, if you have my email down the bottom, you can contact me to get more information, because I'm just trying to, otherwise there may be just on their website, firstcheck.me, I think it is. Oh, hang on, firstcheck.me, yeah. Website, and there may be a contact on there as well. It would be just to email them, but I have got some information for primary health care that I got sent recently I could forward on to people. Yeah, and where do you go to get the iPhone scope? There's a supplier in Auckland that I get it, I bought it from it, so it's Dermlight, and my Dermoscope, my little one, that is a Dermlight 1, and I got it, I can't think of the name of and they have the little attachments for all phone types. I also have an attachment on my iPad as well, so it attaches to my iPad with the
Can having tattoos make it harder to diagnose melanoma?
yeah, it can. Definitely. You do have to really look very carefully through tattoos. I did detect a big basal cell carcinoma in a tattoo, and it did show some white features, and it had changed the colour actually of the lesion. Yeah, it is a bit tricky though.
Should mole mapping be used as an adjunct to regular skin checks? Do they pick up other forms of skin cancers as well as melanoma?
Talking about mole mapping in general, so not within a particular mole map service business. Mole mapping is great because, especially for people that have lots of moles. My advice I often give is to people that if they've never had a skin check, to go to a skin cancer clinician first and find out what their risk profile is. If they don't have lots of moles and they don't have many spots, then they might not need to go down that track. People with lots of moles that are hard to manage when they've had melanoma, the assistance of mole mapping is great. Yeah.
And then we've got, how much sunscreen should we be applying?
It's about 7 teaspoons to a whole body, like to expose skin exposed. So face, neck, arms, lower legs, they reckon about 7 teaspoons. So it's a reasonable amount, isn't it? And so, but obviously it's probably about 1 to 2 teaspoons on the area that we would have exposed. I recommend sunscreen every day on the head and neck all year round.
And then we've got Jen's just acknowledging and saying first check is a great tool for virtual appointments. So just supporting you on that one. People saying thank you. We've got Esteem Healthcare sell the Derm Light.
Yeah, Esteem Healthcare, yes, that's where I got it from.
There you go.
Yep.
And we've got someone saying zinc sunscreen, is it okay to use? As everyone says, 9% or 18% is good.
So zinc sunscreen is absolutely fine to use. All of the zinc sunscreens are tested to the nanoparticle level, so they're a safe amount to have. So zinc sunscreen in New Zealand sun, especially for kids at the beach in summer, is like really, really good. The thing is with zinc, it's a physical blocker. So you don't absorb it, the sun reflects off your body, whereas the non-zinc are chemical blockers, so they do absorb into the skin more.
And then we've got someone saying between Aldara and Effudix, which one would you?
They can be used for differently, so depending on the skin cancer and where it is and what the, yeah. So in regards to how effective, they both are good, yeah.
And then we've got, has there been any progress in applications to the government towards subsidising sunscreens to make sun safety affordable for all New Zealand families and reduce our rates of preventable cancer?
Yeah, if only, it would be so good. Yeah, look, there's a primary prevention steering group working very, very hard on this, and that, yeah, coming up a lot against a lot of brick walls often. We would love to see more done in this area.
And then we've got somebody asking between sunscreen sprays or creams.
Don't think it matters. Whatever suit, you know. Yeah, they're both fine.
And I think here we go. So for places such as southern New Zealand, where we have long periods of UV index less than 3, do you still recommend the use of sunscreen regularly through the winter months? If so, why is that?
Yeah, look, that's a really good question to raise. In Australia, they've been doing lots of work around this and formed a sunscreen group over there too. And they're finding that we're getting, even though our UV level might be down at 3, we're still getting levels of UVA, which is the cause of our basal cells. And the basal cell are just, we remove so many in New Zealand and Australia, and they're doing more and more studies to see if the longer use of sunscreen in our areas will reduce the numbers of basal cells. So they're recommending in Australia now that people should wear sunscreen on their head and neck all year round.
Okay, thank you. And this is your last one. All right, so here we go. Make it a good one. Do you think the reason males are more likely to get melanoma is due to genetics or not being as good at seeking medical care?
Not being good at seeking medical care. Yeah, no, so males are notoriously bad for going in early to get for skin check, for any type of medical conditions actually, and they often don't make the time, they often are working and don't, yeah, so it's an area that in all health that where people are working very hard on.
Great, thank you very much. Well, it's been a pleasure having you with us this evening, Chelsea. You managed to get through 28 questions plus some more there, so fantastic effort, I must say.
Sorry about
yeah, just really good, lots of information that's useful across, I think, the primary healthcare as a whole. I'm sure that everyone's found something useful to take away tonight that they can take back to their practice and to their patient groups.